Hi everyone, we're going to talk today about neurological problems. Section 1 starts on page 75. We're going to begin with some common neurological complaints. And the first is confusion, and it's an inability to think quickly or coherently. You usually will see inappropriate reactions to environmental stimuli that can arise, and this condition can be either temporary or reversible. Age is not a reliable predictor of this. However, most older adults are at risk due to numerous drugs that they are on, the aging process, and any pre-existing dementia and the presence of chronic disease. Dementia is defined as a decline in mental functioning that affects memory, cognition, language, and personality. The DSM defines it as a significant cognitive impairment that is a significant decline from a previous level of functioning. There are several screening tools on table 1.6 that can help differentiate between delirium versus dementia. These tools, combined with an extensive neurological exam, along with labs and a diagnostic test you feel are pertinent, are needed to rule out reversible causes of dementia. Treatment for dementia is disease-specific, and treatment consists of both pharmacological and non-pharmacological measures. Back to table 6.1 on page 77 and 78. Be sure and look at the comparisons of these two conditions. The table brings out the differences in onset, timing, causes, the differences to help you differentiate based on symptoms. It gives listings of the screening tools that are associated with both delirium and dementia, and then treatment options. Non-pharmacological measures that could be used in these conditions include cognitive rehab, exercise, and occupational therapy. Antipsychotic drugs such as Haldol, Seroquel, Risperdal, Zyprexa, and Abilify can be used to treat agitation and aggression, but there's limited evidence on their clinical benefit. And just to note that Risperdal is the only recommended antipsychotic for these conditions and should only be used for 3 months. Next, let's talk about delirium. And it's sometimes called an acute confusional state, and it's important to distinguish between delirium and dementia when evaluating confusion in adults. They share many common characteristics and causes, which is important that you're comfortable with the information that's in table 6.1. Some other causes for confusion can include metabolic disturbances. We know that fluid, electrolyte, and acid-base imbalances, can impact a patient's level of consciousness and can cause confusion. The level of confusion can be related to the extent of the imbalance. Typically, these patients may be dehydrated. They may present with dizziness, confusion, hypotension, may even be in a coma-like state. It's important to get a good history and physical, and that will help lead to diagnosis. Other causes of confusion can include an infectious process, and that's the deterioration of tissue based on the release of toxins in the blood. Severe infections can produce symptoms that are suggestive of delirium, whereas infections that affect the nervous system, such as meningitis, could cause confusion or headaches. Cardiovascular disorders can also cause confusion as a result of tissue hypoxia and ischemia. These patients may typically appear ill, and you might note significant changes in their vital signs, such as decreased blood pressure or an irregular pulse. They may be tachypnic. They can also have swelling, cyanosis, and changes in their consciousness. Next, let's talk about dizziness and vertigo. And these terms are often used synonymously, but they don't have the same meaning. Dizziness is the sensation of unsteadiness or feeling off balance. You could be faint or lightheaded, where vertigo is the false sensation of rotation or movement of the patient or the patient's surroundings. Vertigo can be caused by an inner ear issue or disturbances in the vestibular center or pathways in the CNS system. Episodes are typically brief and mild to severe, but both can cause nausea, vomiting, unsteady gait. The differential diagnoses can be divided into 4 different categories. You could have peripheral vestibular disease, systemic disorders, CNS disorders, and anxiety states. And your H&P are essential in helping narrow the diagnosis down. In peripheral vestibular diseases, these can make up over 40% of all cases of dizziness and vertigo. And most often the problem is located within the labyrinth of the middle ear, and the problem can be caused by otoliths that have precipitated in the labyrinth. When you Google otolith, it refers to it as a ear stone. You could also think of it as crystals that are in that middle ear, and then signs and symptoms of vestibular disease happen when the otoliths shift in this area. It can cause dizziness, nausea, vomiting, difficulty with balance, vertigo, tinnitus, and fluctuations in your hearing. Meclizine and promethazine are the most commonly prescribed medications for vertigo, and these agents suppress the vestibular end organ receptors and inhibit activation of the vagal responses that elicit some of these symptoms. Vestibular exercises can help patients with these symptoms, and the exercises are helpful in dislodging the otoliths. On page 80, be sure and review the diagnostic reasoning algorithm for dizziness and vertigo. It has some excellent information there. Next, let's talk about headaches. And headaches are classified into 2 general categories, primary and secondary. Primary headaches include tension-type headaches, migraines, and cluster headaches. Be sure and review Table 2 that discusses primary headaches and does a comparison of the different types. Secondary headaches are ones that are caused by symptoms of injury or some underlying illness. So on the 3 different types of primary headaches, there's the tension-type headache, also referred as to a muscle contraction headache. Migraine headaches, and these may last anywhere from 4 to 72 hours, and they may present with or without an aura. And cluster headaches usually happen at night, and they can usually present from anywhere from 15 minutes to 5 or 6 hours. There is a headache classification committee of the International Headache Society that offers classifications of headaches and diagnostic criteria. But for primary headaches, other than migraines, they are divided into 4 subgroups. Exertional headaches, headaches associated with direct physical stimuli, epicranial headaches, and other hypnic or sleep-related headaches that can occur in elderly. For migraine headaches, be sure and be aware of common triggers of headaches. Those can be found in box 6.1 on page 83. Migraines can be triggered from hormonal levels, from environmental stimuli, whether it be noises, sun, weather changes. Diet can definitely contribute. Alcohol, sodium nitrates, different vasoconstricting agents such as caffeine, nut pods, chicken livers, yogurt, avocado, certain cheeses, and red wine can trigger migraines. Artificial sweeteners, physical activities, changes in your sleep pattern, cigarette smoking, dehydration. So be sure and review that. On page 87, there's a diagnostic reasoning algorithm for headaches that has a lot of good information that might help in determining what type of headache you are leaning towards for your final diagnosis. So review those. One thing that I do want to bring out in any symptoms such as visual blurring, diplopia, fever, alteration in consciousness, neurological focal neurological issues, and nuchal rigidity. Those all need to be evaluated as there could be concerns for a subarachnoid hemorrhage. In management of headaches, it's important to listen to your patient. If you have someone who states that this is the worst headache of their life, then that needs to be considered a red flag, and further evaluation needs to be completed. Some of those possible causes could be, as we mentioned earlier, an intracranial hemorrhage or some type of meningeal infection. Because the majority of headaches are reoccurrent and chronic, the principal care is to individualize treatment to help meet the patient's goals, and that is to avoid possible triggers, ways to abort an attack, and ways to obtain relief from pain associated with those headaches, and also to decrease the frequency and severity. Management for tension type headaches is focused on the use of NSAIDs and non-pharmacological agents such as cold compresses, stress reductions. Migraine treatment can be divided into abortive, prophylactic, and non-pharmacological treatments. On page 90, there is drugs commonly prescribed for migraine headaches, and it's broken down into abortive and prophylactic medications. It gives the name, and then it also gives prescribing considerations and any adverse reactions that you need to educate your patient on. Non-pharmacological modalities could include biofeedback, relaxation techniques, exercise, deep breathing, massage, hot or cold therapy, and these are all beneficial in trying to help manage pain. There is a complementary therapies for headaches that's found on page 91. Please be sure and review that. A neurological referral should be considered for any patient with episodes of transient neurological deficits, has an increased frequency and severity of unilateral headaches, or has atypical aura. All right, let's next talk about paresthesia, and that's abnormal sensations of numbness or tingling, cramping, or pain without a known cause that travel down the peripheral nerve pathway. A medical history is very important, as it may reveal neurological or cardiac, vascular, endocrine, renal, or inflammatory diseases that could be impacting or causing the paresthesia. Physical exam should focus on the neurological assessment and assess level of consciousness, cranial nerve functions, reflexes, strength, touch, pain, temperature, sensations. The most common diagnoses associated with paresthesia are arterial occlusions, arteriolosclerosis, obliterans, nerve entrapment syndrome, and neuropathies, TIAs, and herpes zoster. So be sure and look at the diagnostic reasoning algorithm for paresthesias on page 94 and 95. It helps to break these down into what your pain is, what type of paresthesia you may have, what test would be appropriate to order, what potential diagnosis could it be, and what your next steps would be in the treatment. Also, be sure and look at the tremors algorithm on page 95. And I think I skipped that, but tremors are rhythmic involuntary muscle movements that result from alternate contraction relaxation of opposing muscle groups. We're not going to go into much detail on it, but they are typically seen with patients that have cerebellar or extrapyramidal disorders, and they can also be related to side effects of certain medications. Let's move on to chapter 7. We're on page 97, and we're going to be talking about seizure disorders. And the term seizure refers to a change in behavior caused by abnormal synonymous electrical activity within the brain. Seizures can be provoked by an underlying medical condition, or they can be unprovoked. The International League Against Epilepsy has seizures categorized into 3 different categories, one being focal onset, a generalized onset, and an unknown onset. Seizures can cause a variety of changes. These can include motor activity with a jerking or stiffening of the limb, an autonomic function such as tachycardia, vision issues where you may start seeing colored shapes, olfactory where you can have changes in smell, language, which could cause aphasia, psychological feelings, which may create something like a deja vu sensation, paresthesia on one side of the body, and then loss in consciousness. As we talked about, a seizure can be caused by that abnormal repetitive firing of neurons in the brain, and this can take place in the motor cortex, the hippocampal formation, and the amygdala complex. Many disorders, including drug overdoses, can initiate seizures. Also, drug withdrawal, head traumas, strokes, infectious tumors, brain defects can all initiate seizures. And one of the common features of all of these disorders is that they can cause the brain neurons to become hyperexcitable. So with hyperexcitable neurons, there can sometimes be systemic problems such as fever, infection, sleep deprivation, or metabolic imbalances such as low calcium, low sugars, low sodium, hypoxia. These problems cause ionic changes throughout the body. These changes with increased extracellular potassium going across the cell membranes can lower the threshold for triggering axon potentials and can cause hyponatremia, which can lead to seizures. There can also be genetic defects in the structure of the ion pumps that can cause seizures, and these are often seen in generalized epilepsy with febrile seizures and benign familial neonatal convulsions. Anti-epileptic drugs such as Dilantin, Tegretol, and Lamictal decrease the hyperexcitability of these neuron cells. When your patient presents, they may or may not be aware that they've had a seizure. They may wake up slightly confused. They could be on the floor or in a different position. If you're evaluating for a presumed seizure, it's important to determine what the timeline of events have been and to see if there's any other conditions that could imitate a seizure, to see if those could be going on. That would include such as a syncope, a panic attack, or a psychogenic non-epileptic seizure. It's important to ask the patient for a description of how the timeline went and the order that they were. Your physical exam should take into the account the time frame from when the seizure occurred. If it's been within minutes or hours of the attack, you may be looking for postictal signs, including confusion, depressed level of consciousness. But if it's been longer lapses of time since the seizure, your main goal is going to be determined by what the signs of the baseline neurological dysfunction could be, indicating if there's a focal brain lesion. It's important to do a full neurological exam to be able to evaluate for focal neurological symptoms. The management of seizures is to prevent the recurrence of seizures with anticonvulsive medications while avoiding adverse effects for the drugs. These patients need to be referred to a neurologist so that the type of seizure can be identified and classified and then appropriate medications prescribed. On page 101, differential diagnosis 7.1, there are different types of disorders and the specific condition associated with seizure and how the two interrelate. I encourage you to review those. And then on page 102 and 103, there are the different classification of medications that are used for seizure activity. They describe what the medication is, its indication for use, prescribing considerations, and then any adverse reactions. Our role as practitioners could be that we monitor the patient routinely for side effects and seizure control. It may include, based on the medication, checking drug levels to make sure that the drug is at the appropriate level. But when things are not within a controlled range, then the patient needs to be sent back to neurology. Okay, apparently I did not advance the slides far enough while we were going through different parts of seizures, but be sure and know that diagnostic tests could include CBCs, electrolytes. You could do EEG, CTs, MRIs, possible LP, TAP. We talked about differential diagnoses and syncope, and then the psychogenic non-epileptic seizure condition. I think we talked about management and the medications, so let's move on to Alzheimer's disorders. And we are on page 105. We'll do Alzheimer's and Parkinson's, and then we'll finish out this first part of section 1. So Alzheimer's is a progressive neurodegenerative condition that is the most common form of dementia in the older population. The statistics say that 1 in 3 elderly individuals dies with Alzheimer's or another form of dementia. It is characterized by a slow progressive cognitive decline, and there can be a variety of emotional and behavioral problems that result from the cognitive decline. These patients may have difficulty learning new information or recalling previously learned information. They can have issues with aphasia, apraxia, or perception, which is agnosia, and then they can also have issues with executive functioning. Subjectively, these patients may present with initial complaints of memory loss, and objectively, the patient may have concerns about cognitive decline, but you may receive input from family as well. There may be changes in behavior. Cognitive assessment is very important in the diagnosis and management of dementias and should be performed with all patients. Routine social conversations and questions that can be answered automatically are not going to give you insight into symptoms of early Alzheimer's. Instead, you need to probe the patient's memory a little further and ask questions such as, what did you do last Sunday, or what did you have for breakfast this morning? Things that they're going to have to think about, and things that may not come as easily. It's important that you focus on history, documenting the signs and symptoms related to the dementia. You want to include the onset, the duration, and any stepwise or continuous progression. And you also want to know if there's any family history. It's important to assess for any other medical problems that could be causing cognitive impairment, and these include medication side effects, could include thyroid disease, low B12 levels, depression, anxiety, and sleep issues. There is a easily administered bedside test to assess for cognition, and that's called the Montreal Cognitive Assessment, and this would be an easy test to be able to perform in the office or in a hospital setting if necessary. This test asks the patients to name the months of the year backwards or spell the word world backward to evaluate their attention. They say these are 2 very easy ways and quick ways to do an assessment. Be sure and look on page 107. There's an advanced assessment on 8.2, which assesses functional activities questionnaires to better assess if your patient is having any issues with these everyday functions, such as maintaining financial records, shopping alone, being able to heat water on the stove, and remembering to turn off the stove. So be sure and review those. As we mentioned throughout the book, they offer lots of diagnostic algorithms, and there is one for Alzheimer's disease. So be sure and review that. When we're caring for these patients, the principles of management are directed towards slowing the progression of the disease, and we can do that with medications, but also protecting physical health, providing emotional support, and maintaining optimal function. Both the patient and the family may need help in understanding and coping with the diagnosis of Alzheimer's. Most patients are very eager to try approved and research staged medications to help with the disease, but also be aware that of other modalities that can help, such as support groups. It's helpful to both patient and the family, but needs to be relevant to the stage of the disease. It's also important to recognize if the patient has any anxiety or depression, so these can be treated along with the Alzheimer's. Two things the book notes on treatment is that medications, may improve cognitive function in mild to moderate Alzheimer's. Cholinesterase inhibitors are the drug of choice, but one key that it mentions is diazepam does not prevent progression of Alzheimer's, but it does seem to slow the rate of decline. So on page 109, it has drugs commonly prescribed for Alzheimer's, so be sure and review that. These patients also may benefit from being referred to a memory disorder center. This type of center offers multidisciplinary services that can help with medication management, support groups offering better overall care. Next, let's talk about Parkinson's, and it's a chronic progressive degenerative disorder of the basal ganglia. The disease can usually begin slowly, but can lead to disabilities. It has several symptoms for Parkinsonianism, which include rest tremor, rigidity, bradykinesia, postural instability, a flexed posture, and freezing. If you are not familiar with anyone that's ever had Parkinson's, be sure and look on page 111. There's a very descriptive picture there of one man's depiction of having Parkinson's disease, and just be sure and look at that picture, because I have the Parkinson's patients that I have cared for. I think this is probably a good summary of how they might feel. With Parkinson's, usually the history and physical lead to the diagnosis of Parkinson's disease. The management includes control of symptoms, because there's no drug or surgical approach that's been found to prevent the progression of the disease. Treatment is lifelong, and the goal is to keep patients functioning independently for as long as possible. The decision of when to start treatment is very individualized, but the common theme is when Parkinson's syndrome symptoms begin to interfere with activities, it's time for treatment to be initiated. Levodopa is the drug of choice for Parkinson's. On page 114, there are other commonly prescribed drugs for Parkinson's disease, so I would be sure and review those. Follow-up and visits are based on the patient's response to treatment, if they're having any adverse effects of the medication, and then also based on disease progression. So sorry, there's one more topic in this chapter that we'll go through real quick, called amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. It's a progressive neurological disorder that destroys motor neurons. It can happen in both the upper and the lower motor neurons. The patient may present with a foot drop or other localized motor symptom, and then over time weakness will spread to other areas of the body. Survival rate is typically from 3 to 5 years. There's no treatment to reverse ALS. However, treatments can slow the progression, and the only medication that has been shown to improve survival in ALS is the riluzole. It's unknown how it works, but it may be related to the reduction in the excitotoxicity caused by the chemical messenger in the brain called glutamate. All right, that's the end of section 1. Thank you for your attention.